I need to wake up. Hi, Elizabeth. Thank you for joining me. It's finally Friday. This was the longest week ever, I think. I say that a lot, but this week I felt every day of the week. Hi, Edel. How you doing? Um, let's see. Make sure my email is pulled up. Nope, not what I wanted. Excuse me. Here we go. Meet. Hi, Miss Rue. Thank you for the blue heart. Yes, happy to see you again. Well, I'm gonna be gone for a whole week, but y'all will still have pre-filmed shows from me for next week. So from the 9th through the 13th, yes, the 9th through the 13th, we're gonna have a Friday the 13th. So from the 9th through the 13th, it will be all pre-filmed shows. Please be sure to watch. Let me know that you're watching. I may or may not be at the premieres. It all depends. I have a lot of things that I'm going to be doing next week, and that's why I just needed the time to do it, so that way I can devote time to you guys when I return to my live glory on the 16th of this month. Are you taking a vacation? It's not technically a vacation, Elizabeth. It's more of like chores that I have to do. So it's just a lot of the stuff that I have not been able to catch up on, and there's just some things that I need to take care of. So just to have the time to do it, I just need the time off to do it. So I'm taking some time off from work as well, so I'm really going to be able to get a lot of things done, hopefully. Fingers crossed. Because there's nothing like adulting, right? That's what we're doing, right? Adulting. But eventually I will go back to vacations. I miss taking vacations. Elizabeth, we all know those times, those things take time. Yes, definitely. And I was on time today. So I hope you guys caught up on the episodes that you may have missed. Today we are going to be talking about how to email your providers educational tips. That is something that I do on a regular basis. I've been kind of slacking the last month on it because of the simple fact that they're okay. And when they're okay, I feel like, okay, I don't really need to do this. And then all of a sudden I start to remember why, why this is important to do on a regular basis. Hi, Ashley, and hi, Aurora. I'm so glad that you're back to regular time. And thank you for the blue hearts. Okay, so let's go ahead and get into it. If you are brand new to my channel, welcome. I am Blue. I'm a medical coder. Today, I am talking about how to email your providers educational tips, right? So this is something that I started doing a few years ago now. I started doing this thing called Coding Tip of the Week. Now, this is very popular. They like it because it's little bits of information. See, what happens with providers when they get a lot of information from us coders all at one time, they get very overwhelmed. It's easy for them to get overwhelmed with all this information because it's like, I'm not a coder. Yes, I know you're not a coder. That's my job, you know. What I need you to do is make sure that you're giving me the appropriate documentation so that I can give you the appropriate codes and the appropriate procedure codes so that we are all on the same page in the same sheet of music. So typically what I do is as I'm going through the week, I'm looking for things that I'm seeing, like a trend. If I'm seeing people forgetting laterality, which laterality is not typically an issue anymore, thank goodness, although knock on wood, you know, the second you say it, right? It's typically not an issue, but sometimes they can backslide and they'll say the patient has a broken femur, and then they'll talk about the plan of surgery, and then they'll leave off which femur. So it's very important that they document laterality. They document as much as they can when it comes to the specificity of where it is. Okay, so that way we know. If they're talking about fractures, is this a displaced or non-displaced fracture? If it is not, if it's not, we know if it's not stated as such, then we are going to default to the displaced. But that is an educational thing that you can bring up. And I'm going to read to you guys the example that I have today. This is a email that I actually sent today to my providers. So this is actually what it looks like. If you are interested in doing something like this, I recommend that you look at some of the issues that you're having in your clinic, right? Don't try to hit them all at one time. Hit one thing at a time. When you are doing a coding tip of the week, it needs to be one thing, okay? Rome wasn't built in a day. So trying to correct all the problems of your clinic is going to take time, okay? And it takes little by little by little. They will accept these breadcrumbs a lot better than they will just a bunch of information all at one time. So this is what I wrote to them. Greetings all. This week's coding tip of the week is about and versus with. When documenting a patient's condition, the use of either of these words can completely change the code selection. Please see the following example below. Right worse than left bilateral knee pain and mild to moderate arthritis. In coding terms, this would be coded as M25.562 pain in the left knee, M25.561 pain in the right knee, M19.90 unspecified osteoarthritis, unspecified site. This is the guidance from the 2021 official ICD-10-CM guidelines for coding and reporting, page 11, section 14, and. The word and should be interpreted to mean either and or when it appears in the title. In contrast, the word with used in the same scenario would produce the following code. Right worse than left bilateral knee pain with mild to moderate arthritis, M17.0 bilateral knee osteoarthritis. Knee pain is a symptom of knee osteoarthritis. Therefore, it would not be picked up in addition to. From the guidelines, page 11, section 15, with. The word with or in should be interpreted to mean associated with or due to when it appears in the code title. Unspecified diagnoses will often flag encounters. This will lead to delays in the billing process. If you have any questions, please advise. And then I put on there my return to work because I was letting them know that I was going to be on leave as well. Thank you and have a great weekend. And that is how I do mine. It's right to the point. I give them my reference, which I reference the coding guidelines, and I'm telling them exactly where I see it in the coding guidelines. They all have a copy of the coding guidelines. I make sure they have a copy every year of the coding guidelines, or I send them the link to make sure that they have it. Because I want them to know that what I am sending them is coming straight from the guidelines. Now, let me explain this in a way that us coders can understand, right? So it says right worse than left bilateral knee pain and mild to moderate arthritis. So we know when we see that arthritis, that's by itself because it's separated by the word and. According to the guidelines, the word and should be interpreted either and or when it appears in the title. So this means that there's a separate break in the between, right? Because arthritis can be anywhere. It doesn't necessarily mean that the patient has the arthritis in the knees, because the provider states and bilateral right worse than left bilateral knee pain and mild to moderate arthritis. Where is this arthritis? It's not linking it together. It's not It's not putting it together that's associating that knee pain with that arthritis. Is not doing that because the location of the arthritis is not specific. Okay. Then you have with. Right worse than left bilateral knee pain with mild to moderate arthritis. So from the guidelines, it says the word with or in should be interpreted to mean associated with. So if we were to read this again, we would read this as right worse than left bilateral knee pain associated with mild to moderate arthritis. So that's letting us know, okay, this is in the knees. So we can completely eliminate that knee pain because that knee pain is a symptom of the osteoarthritis of the knees. So that's how we get rid of that. And that's how we have the M17.0. This is how one word can change the meaning. And this is when you start getting into clinical documentation improvement, when you can start making these, and even when you're doing the coding, you can start making these educational tidbits known. Because again, we're looking for specificity. If the provider is meaning that the patient has knee pain, and they could have any kind of osteoarthritis, right? I mean, any kind of arthritis. It could be rheumatoid, it could be osteo, it could be any of those, right? So they have to be more specific. When we see arthritis, okay, we're going to know. In this situation, if they had the word with, we're going to know that it's of the knees because that's where the pain is. This is associated with the arthritis. So that is how we're able to narrow that down. And it doesn't take you having the official title of a CDI in order to come up with that either. This is just an example of like the holes, finding the holes. So when you see something like this, it's not automatically assumed. And you don't want to pick up something that's unspecified, like that unspecified osteoarthritis of unspecified site. Because a lot of times that's what these insurance companies are looking for. Oh, you don't have a specific location, although you're talking about a specific location in your note. Okay, we don't have to pay. So this is what I'm saying, getting your providers into good, healthy habits, because they're going to come at you like, that's stupid. It's saying it right there. This is when you have to explain. According to our guidelines, this is what we see as medical coders. This is what our rules have told us that we have to follow. Because if somebody like me just picks up arthritis of the knees because I'm assuming that knee pain is related to that arthritis, right? Even though it's not connected, I could be wrong. It could be arthritis of the wrist, but not the knees. Or the thumb and not the knees. It could be anywhere. So it just really all depends. So that's why I'm saying the more clear we can drill down this documentation, the better. And taking it little steps at a time is what's going to help. Because if you try to go in there and you're going to blast them with all of this information, they're going to stop listening to you. This was just enough to be like, okay, I'm going to be more mindful when I see the word and or with. I know Bleu said something about and versus with. So they can go back to this, see what I'm saying. Oh, okay. So they know that if it's going to be associated with that, they're going to use that word with. If it is two separate things, which I just showed them the example of that, right? How it'll show two different things. I know I used the word and. So you'll get used to it after a while. Once you start doing this, yeah, you'll get used to it. Hi, Simone. Jill says, at my old job, we had to CC our coding manager and other coders every time we emailed providers. That made me feel better. So when it comes to doing that, sometimes there's a process, right? There is rules, and every facility is different about how we do like queries and stuff. I send my queries directly to my providers. I don't copy 100 people on my emails simply because when those providers see not just them, but they see myself and they see my, like a whole team of coders plus the coding manager and all this, then they're like, okay, no, this is too much. There's too many people here on this email. So for me, what I do is, this is my communication with them. And yeah, there's rules, but at the same time, that's my clinic. These are my providers, and I'm going to educate them because that is my duty as well. So unless something happens, but of course you see that I have used my references. And again, it just really all depends on your facility. But for me, I am most comfortable when it is just us talking, because when you start to incorporate more people, then if they don't like something that you say, oh, well, I know I can go to your manager and ask. Go ahead. But my manager is going to agree with me because you have to have that united front. If your manager says, oh, no, well, and maybe you are correct, but the manager wants to say something else different, or maybe the manager's experience is a little bit different from yours, and maybe they just don't understand something, and maybe they say something different to the provider. Now you have two different people saying two different things. You can't do that. When it comes to provider education and communicating with them, they need to see a solid united front. My supervisor understands, because I have said this many, many times. I have drilled this down to a science. We have to show a united front. We cannot be arguing with each other. We cannot disagree. We can disagree with each other behind closed doors, not in front of them. We can always send out a retraction email, but we cannot disagree in front of the providers, ever. You don't ever do that. Because if you want them to not listen to you, oh yeah, do that. Make a scene. They won't listen. It's all about building that trust. If you build that trust, and they say, okay, well, not only did Blue say it, but her manager said it, and the other coder said it, okay, so that's the way we're supposed to do it. The coders said this, right? Not, oh, well, Blue said it this way, and somebody else said it this way, and the other person said it that way, and then I heard this over here, so I don't know who to believe. So that's why I say you have to make sure that you lay that foundation of, we got to build trust here. This is us building trust. And for some people, it's, I mean, that's what they do, and it makes them feel better. That's fine. It's whatever is comfortable for you. But for me, no. My boss knows what I do. She understands the way that I've done my education. She's modeled a couple of her ideas after my idea. So, I mean, it's not like it's my first rodeo. You know what I'm saying? Like, I've done this several times, and so it works. My education things work. And she has out-processed some of my providers who have left and gone on to different facilities, and they've always told her, you know, Blue does these really cool coding tip of the week, and I really like those. And for those providers, I still keep them on the email traffic for coding tip of the week. So some providers that I've had before that are no longer at my facility are still on this. And so they still get coding tip of the week. Because I tell my providers that even when you leave me, it doesn't mean that you can't ever reach out and ask for my help. Because again, everybody is different. Every facility is different. And some facilities don't have coders for their providers. So I said, if you ever get stuck and you get in a situation like that, you call me, you email me, you let me know, and I'll be Janie on the spot. I'll be right there. So, you know, they were like, thanks, Blue. But it's what you got to do, you know? And so that's what I tell them. You know, I mean, for some that, you know, I know that they're going to take my advice, and yes, you know, absolutely. But there's only been a couple of them that it's like, okay, bye, good luck. Guy says, yes, Blue, you are right. As you said earlier, Rome was not built in a day. It just looks that way. Yes, it does. Rome is amazing, although I've never been there, but one day, you know. But yes, provider communication can be fun, especially when you make those breakthroughs and they're willing to accept this information from you. It can also, I will caution you guys, it can also be very frustrating because you have to prove yourself, you have to prove your knowledge, you have to bring your A game essentially, because you have to be ready for whatever they're going to throw at you. Because sometimes they're going to be like, well, I don't have to listen to you. I'm the doctor. You do what I say. It's not about you do what I say. It's about, hey, I'm trying to help you. We're a team here, because I know the coding side and I know what's going to get this thing cleared and processed well, because it's got all the information that it needs. And you're the provider. You're going to be the one who's documenting all this stuff. This is going to benefit you, because not only are these bills going to be cleanly submitted, but you're also going to have a full and accurate record for yourself to reference back every time you see your patient. So that is something to think about. It's not just about copy forward, copy forward, copy forward, which I can't stand copy forward. But, some providers just do that. That's the thing. You have to be very careful with a copy forward, because with copy forward, things can change and things can update with these patients and their health. And so you want to get the most accurate, up-to-date information, not something that's old. So, that is part of the educational process. But picking little things to talk about with them, like me telling them the difference between and with, the difference between the two, that is going to go a long way into helping them. Okay, because now I have to think when I say and, I have to think when I say with, is this meaning this? It's just like the word history. When they say the patient has a history of diabetes, the patient may have a history of diabetes, or they may currently have diabetes. Now you, as a medical coder, have to go through the documentation and you have to check, is the patient still on medication? Are they still getting treatment for diabetes? You know what I mean? That kind of thing. So that way you can confirm that it is not history, that it is actually a current condition. And that provider needs to be educated that these conditions are current. This is not history. Because for us in medical coding, when we see history, history means it's gone. It's no longer there. And so it can be taken as conflicting information, right? So that's something that you have to put on your list of things to talk about with your providers. History, being very careful with that word, because history to us means that it's gone. Claire says, good evening, Blue. Thank you for addressing this topic. I am starting to get my toes wet with provider education, so I appreciate it a lot. Yes. And this is part of our education as medical coders that we don't get, right? That how to. I have issues with the history of DVT, PE, and especially cancer, still working on those. And see, that's the thing with DVT, right? Because sometimes they can have a history of it, but they're on like medicines to keep it from prophylactically, right? To keep it, not there. So that's something that they have to be educated on as well. You can have a history and still be on medication for it. That is fine. So you can have a history code, and with something like that. It doesn't necessarily mean that you have to have the actual diagnosis code for a DVT or a PE. They can have the history and still get the medication code for it. So, but it is showing what they're still on. That is something that's very serious. The same thing with cancer, are they still being treated for it? Is it in remission? And that kind of thing. That is something that some providers are very, like they get real uncomfortable with putting that kind of thing because they don't know. Well, when you don't know, tell us what you do know. Tell us what you do know, so that way we can accurately and appropriately pick up the code, But like I said, when you are educating these providers, make sure that you have your references. Just like I talked about in that, I referenced the official coding guidelines. I showed them in an example what the codes would look like, because that is what we're seeing. So that way that they can understand that. Because when you show up without your resources, without your references, which I have seen happen before, and I have to hold my tongue because it's just like, how did you not know to bring your references with you? And you have the coder saying, oh yeah, well, that's the way we do it. No. You have to show the provider why you do it this way. Because if you're saying, well, we do it this way, they're going to think in their head, oh, well, they're making me do it like this because it's easier for them. It's not. It's not because it's easier for us, right? It's because we have these rules. And sometimes with some people, they will do these types of things because it's what somebody else told them, but they don't ever really understand why that they're doing something, right? So you need to make sure that you understand why you are doing a particular thing. If it is a particular rule set for your facility, that's something different. But if it's something because everybody's always done it this way, you need to verify that you're actually doing it correctly, because doing it the way it's always been done is not the answer when you get called on the carpet to answer why did you select this when it goes against coding rules or something, right? So just make sure that you're covering yourself as well, understand why. And that is the whole deal. When you start to understand the whys and you can start to explain it, it starts to get a little bit easier and starts to get better. Sometimes when I'm talking with my Uncle Kyle, I'll talk with my Uncle Kyle in the evenings and I'll explain to him some of these things. And sometimes I think he's not listening. He's listening because I'll bring it up later and I'll say something that happened in an email or something like that. I'll say, oh, well, I was coding this one and I was trying to explain. And then he's like, yeah, man. And then he'll explain the rest of it before I can even finish. And I said, so you were listening? He goes, yes. And he goes, even I know that. So, but it goes a really long way when you can start to explain things to people, especially people that are not even in the field. And if they can explain it back to you, then you know you've done a good job of explaining it. So, but it all depends. It depends on you. Please don't get discouraged or disappointed, or that you don't want to do it because you get kind of, a provider may come at you. They're going to come at you because they don't know, and they want to make sure that you're actually telling them something that's legitimate, so sometimes you may have to come at them a couple of different ways. For some providers, they prefer straightforward, no fluff. Okay, great, we got that. Some like the fluff. Some want all the fluff you can give them, as far as like all the details as to why, and then then they'll be like, okay, and some of them it's just going to be just a matter of their personality. How is their personality? Because if you get stuck and you can't explain something to them, try to enlist the help of somebody else to figure out, like, how can I communicate with this provider that's not listening? What is it? What else can I do? Because sometimes that's what it needs. That's what it needs. You going to somebody else to ask, hey, how can I reach this provider? Like, what is the deal? How can I get through to them? Because these providers, like I said before, they all have different personalities, and some of their personalities are very studious. So their social skills are a little weird, and you have to kind of work with that as well. So sometimes they may not show you any emotion, and you may think, oh, they're not listening, and actually they are. So that's why I say always be consistent with your approach. And when they start to get used to you, that's when the magic will start to happen. So, but it is a matter of you putting yourself in that position and not letting anything or anyone stop you from sharing. And if you're excited and happy about something with coding, it's okay to share that. Because that natural reaction that they see, they love. They enjoy that, actually, because when I've had these moments where I completely freak out and I see something that is so awesome and amazing, especially in their documentation, when they're doing something exactly like they should, and I go over there and I tell them, they love that. They just start laughing at me because it's just like, they go, really, Blue? You're such a nerd. And I'm like, yes, I am. And I go, but look at this, isn't this cool? And they go, yeah, and so they like that as well. So you can be naturally yourself. When you're happy, let them know, because they like that too. They need to know that they're doing a good job as well. If you see something on there that is really good, let them know. Dr. So-and-so, I appreciate you taking the time to attend the educational classes or whatever, and Thank you so much. It's reflecting in your documentation. I'm thrilled. You know, I'm excited about it, or some language like that, something that says that you really appreciate what they do. What was one thing that I said? I got so excited one time about something. I can't even remember what it was anymore. But I said to that provider, I said, it's providers like you that how did I say it? Is providers like you that make my job worthwhile. And so later when I saw that provider, they were smiling and grinning, you know, because they were like, really? And I was like, yeah, because it is a struggle sometimes to get through. I said, but when I make those breakthroughs just like this, that's the best. It is the best feeling ever, you know. So at least I think so anyway. So all right. Does anybody have any questions about this, about educating providers, or what you should do, or? Yes, no, crickets. All right, guys, because I'm going to be gone for a whole week, but I will be here in pre-filmed videos. So be sure to watch. Like and subscribe and share, okay? Claire says, yes, do you get to sit down with them for longer periods of time? Yes. Sometimes it just takes me kind of like walking around and going to them. And sometimes when they see me and I make myself accessible to them, then they're like, oh, hey, by the way, I have this question. And then so when we start talking, sometimes I'll look at the clock and an hour will have gone by. It happens. Sometimes it's 30 minutes, you know, but when you make yourself accessible, they will be like, okay, yeah, by the way, while you're here, because sometimes they're not always going to go to your office. They're not always going to reach out to you on email. That is almost going to be a rarity that they reach out to you on email. It is about putting yourself in that right place at the right time. So that way they can be like, oh yeah, well, while you're here. Claire says, most of what I've done is I've gotten little emails, queries, and so shorter periods of time and not in person. I am really, really hoping to set up a virtual office hours since we are all remote. Guy says, gone for a week. What am I to do? Oh, Lordy. You're still going to have pre-filmed shows, Guy, so don't worry. I've got a bunch of really good topics coming up, but I will release them every single day, like in the morning, because I have a reason that I do that, but I have to do it that way. So guys, just trust me on this, okay? But you will have episodes every day, so don't worry. You won't not see me for a whole week. Plus there's, what, 600 plus videos? I don't even know how many videos I have up. But yes, getting back to Claire, your question. It is about being accessible. I know some facilities are virtual right now, and so that is what you have to work with. So, I mean, that's totally fine. You got to make it work. I mean, just make it work, whatever you do. Claire says, for 2021 guidelines, do your providers document time at all? Any advice on encouraging them to do so? Yes, they do. Some do and some don't. Some I'm having to still work with them because they're kind of scared. They've had it drilled into their head this whole time about the time. And so now that they're able to do it, now they're like, well, you know, and so they're kind of scared of it. So you have to educate them. And I tell them the same thing. If you have a patient that's coming in for a follow-up, and this is going to be your normal routine follow-up, and they're essentially okay, but this patient won't stop asking questions because maybe they're scared, or maybe they have some concerns about something else, or whatever the case may be. That time that you're spending talking to them, reassuring them, if it is longer than your typical visit, like maybe it's 15-minute visit, and it turns into a half an hour or 40-minute visit, now you're looking at a higher level because you've had to spend time counseling this patient. You should get a level based on time for your time, because your time is valuable. because the more time you're spending with this patient, now your whole clinic is going to be backed up because you have a patient who just couldn't stop, but you had to spend time to educate them about their condition or talk to them about this or reach out to another facility about this patient, that kind of thing. So all of that work needs to be, accounted for, and all that work needs to be compensated appropriately. So I do encourage them that if it's taking longer than typically would be on a normal basis, document your time. And on the other side of that, right, they say, well, Blue, what if we only spend a half an hour with them, but I'm deciding to do surgery? Does that mean I only get on a brand new patient a 99203? No, it doesn't. If you've decided to do surgery, but yet you only spent 30 minutes because you were able to get all of this stuff done as quickly as possible, right? And sometimes it happens. Sometimes it's pretty well straightforward. Okay, the patient, okay, we're going to do surgery on you. And it's within 30 minutes, and that's what they have time. They documented it just on chance that they said, okay, 30 minutes. But you're setting them up for surgery. You're doing that. You had to decide that. That's a higher level. So that's going to go based on medical decision making. Just because you document it as the time does not necessarily mean that's automatically what you're going to get. If your medical decision making outranks your time, you better believe that you're going to get it based on medical decision making. So, that is something that you can reassure them about, and tell them what all encompasses that time. If it's just really quick, and they just spend 15 minutes and it's just your normal routine visit, okay, well then that's just going to be your regular routine visit, your normal level, whatever, and go from there. But when it comes to those higher levels and you're spending more time, if you're spending more time, then you need to make sure that time is documented. Well, I didn't hold a stopwatch. No, but you do know how much time you spent in there with the patient. So, that's the thing that they need to know. Also, they have that whole day. So they have before the patient arrives on that same date of service. And then they have the visit with the patient. Then they have the time afterward, what is called pajama time. And that is like if they have to leave work and they come home and they finish documenting on the same day and they spent another half an hour documenting, they can add all of that time together. So it is the entire date of service that they are working with on that time. So that's what you can tell them as well. If you're taking this work home and you're documenting at home and it's still the same day, and if it's like a lot of time, like a half an hour, okay, well then go ahead and put that on there and make sure they note in there, this time was spent, additional time was spent documenting, and just a brief summary of why they spent so much time. Records had to be reviewed, phone calls had to be made to this, such, and another, right? So just a brief synopsis about what happened, why there was all that time, and you're covered. Naturally, if they're saying that they spent 120 minutes with every single patient, come on, man. There's not even, you start doing that and you're going over 24 hours a day. Now, come on, that's a little ridiculous, So obviously don't go crazy with it, but use it within reason. And that is normal. That is acceptable to use it within reason. Now, again, if you're saying every single patient that you do as a 5, come on, man. No, that's ridiculous. Not every patient you do is going to be a 5. I'm saying. Anything to do with fancy cars. What are you talking about cars, guy? Claire, this makes a lot of sense to me. Let's make sure you are compensated for your work, LOL. 120 minutes for each patient. And see, they're having to get paid for their cognitive work. And so all of that additional time, that is supposed to be compensated. So think about that. And that's something that they may like to hear as well. That because they like to say, well, we don't get paid appropriately for what we're doing. You need to document so that you can get paid appropriately. You need to make sure that your coder is educated and educating themselves continuously so that everybody's on the same page and everybody's working together to make sure that you're getting appropriately paid. Claire, follow up. Are your providers good about telling you whether it's major or minor surgery they're planning? It's hard for me to figure that out sometimes. Low versus moderate risk. The way that I do this, and the way to know, is you got to know the global days of the procedure, right? So if they're telling me that they're doing bilateral knee injections, that's a 0-day global. That's a minor procedure. So that they're not going to get an E&M unless that E&M is related to something else, okay? If that condition is requiring them to get injections on their knees or injection in their shoulder or something like that, that's a 0-day global period. That means that evaluation and management's already built into that procedure code, okay? You would not get a evaluation and management for that, even if you decided it that day, even if that patient is brand new, okay? Because again, they've already calculated that thought process into that minor procedure, or that minor procedure. When you're talking about major procedures, that's a 90-day global procedure. That's the one where they're going to have to take them up to the OR, or if you are working in the orthopedic clinic and they're saying they're doing a closed treatment or even a treatment with manipulation, that's still a 90-day global procedure, even though you're not going up to the OR, okay? And that is just knowing your procedures and what constitutes a major procedure, which is the 90-day global period. Do you have that Palmetto website, Claire? Let me see. I'm going to give you this website. I don't know if you have it. I don't remember if you were there that day. Yes, okay, good. Well, I'm going to go ahead and put it in here for anybody else that needs it. This website right here, you can type in the procedure, the CPT code, and it will tell you how many global days are in that procedure code, right? Or for that procedure code. Or if you need to calculate how many days is 90 days out. So say, for example, the patient had the surgery on February 1st. You would put into the global surgery calculator February 1st, and it'll tell you how many days 90 days is from February the 1st. So it's a really good website, and I left it there. But that's how you're going to know. So if you put in that procedure code, you'll be able to know if this is going to be a minor procedure, or it's going to be a major procedure. That way you know major risk versus a lower risk. Claire, I was just confused because I thought that major versus minor was no longer tied to global days for the 2021 E&M guidelines. Rather, it's supposed to be whether the provider considers it to be so. No. No. Okay. If I'm understanding you right, okay. The provider is going to decide to do a procedure. We know whether that procedure is going to be major or minor, right? Because we can put it into the calculator. If the provider is saying that the patient is at high risk because they are diabetic or they have DVTs and things like that, that's putting the patient at a higher level of risk, right? And so then they start putting that in, that's going to up your evaluation and management level. Am I following you? Okay, I want to make sure. Because sometimes I'll think some way and then that wasn't what they meant. Okay, okay, good, I'm following you. But yes, that's why. Again, if we are seeing that this patient has a ton of different diagnoses, that provider really does need to say, okay, is this patient a high risk? If they're high risk, well, then, make sure that you're documenting it. This patient is high risk because of, this complication or that complication. That's something that it would help. But again, we need to look and comprehend what we're reading when we look at this documentation and we're looking at all their conditions that they're coming in with. It is about understanding that part. So hopefully that answers. Does that answer that? Hopefully, yes. But yes, it's a journey sometimes with these providers, because I've had a that does answer that. Thank you. Good. I've had to lock horns again with some of these providers. Some of them, you know, were a little bit harder than others to work with, but some of them came around, so that's always a good thing. Uh, Guy says, please have a good time on your time away. I will. Thank you so much. Yes, if you're commenting, it may be a little bit of a delay. My Patreon subscribers, though, will have first priority with response time. But that's just for this coming week, so that way, you know, if you guys have any issues or whatever, just, you know, comment, you know, but just be patient. Because like I said, I try to be on top of these things, but I know for this coming week, it's just going to be, and I want to make sure that I take care of everything, but you will hear from me. So again, I hope that you guys will watch the shows that I have out. Because that would be really appreciated while I'm on my time away. Lets me know that y'all support me. Am I going somewhere? No, not technically. I'm just doing a lot of adulting around. Okay, so that's what it is. A lot of adulting. Drea says, do you do CPC exam prep? Okay, so people are asking me lately, do you do CPC exam prep, CCS, CCA, RHIT, RHIA prep? So what I do is this. When I do my tutoring, is what I do. I do tutoring. What I do is I offer my time, right? And you can book an hour, you can book 2 hours, whatever. And of course, there's a charge for it. But what we do is we meet over Zoom, and you tell me what issues that you're having, because there's really kind of no way for me to gauge and know what you need, because some people are more proficient on CPT coding than they are on PCS coding. And so, Blue, I need help with PCS. Okay, well, you got it. Oh, Blue, I need help with CPT. I'm okay with PCS. All right, let's go this way. So it really all depends. I tailor the tutoring to each person, so it's whatever you need help with. There's really not anything that I would be lost on. You know what I mean? Like, I have so much experience, so there's not anything that I would be lost on. I've never sat for a CPC exam, no, but I do have a CCSP, which is a Certified Coding Specialist Physician based, and that is the mastery of the outpatient setting. So it's not like I wouldn't be able to pass the CPC exam, right? And the CPC exam, I've prepped many people for that as well. So it's something that I would be able to do. Same thing with the CCS, same thing with the CCA, or even the CCSP. So even with the degree ones, because it just depends on what they're asking with the degree designations. Because the degree designations is more of like on like the legal side, the statistical side, and things like that. So there's not really a whole lot of coding on those exams, but you know, we'll just, I mean, whatever, you know. But yeah, I'm here to clarify. So that is what I do, because I do know how to find the answer. So but yes, my current rate is $25 for the first hour, $15 if you need an additional hour in the same session. And again, we meet over Zoom. I take PayPal and Zelle, PayPal or Zelle, so whichever one you use. And yeah, I'm available after 5:30 p.m. I try to go a half an hour earlier. So 5:30 p.m. Central Standard Time during the weekdays, after 10 a.m. on the weekends. From the 9th to the 13th, I'm not available though. But on the weekends, I will be available. So y'all have availability until Sunday, and then Monday the 9th, I will be unavailable all the way till the 13th. So if you want to get any time in, make sure you do it before then. If not, you'll have to wait for a whole week. But yes, that's what I do. Hopefully that answers your question. Claire says, thank you so much for your advice, Blue, and I hope you have a fantastic week. Oh, thank you for the blue hearts. Thank you. Drea, okay, thanks. Okay, good. So I guess with that, thank you so much for the likes, the thumbs up, the shares. Thank you. And I will go ahead and wrap this one up. Thanks again for joining me, and I will see y'all again for live on the 16th. But again, join me for my pre-filmed shows during the week. And I hope y'all have a great week, and I will see y'all next time. Bye.